This is Dr. William Audeh, Chief Medical Officer for Agendia, and it is my pleasure to review with you the updates to our Mammoprint and Blueprint Summary Report. These changes and updates were undertaken in response to feedback from you. The summary is made up of 4 pages, with the first page containing the majority of the information that will be of value to you. The subsequent 3 pages include data and graphs showing the validation from clinical studies supporting the clinical implications described on the first page, as well as references from all of the studies performed. Looking at the first page, you have the patient's name, age, date of birth, and other identifying numbers at the very top, following which we have clinical information which you have provided at the time of the test request regarding receptor status, estimated node status, tumor grade, tumor size, and specimen type. If, however, at the time that we received the sample, the receptor status is unknown, the report will default to a hormone-positive, HER2-negative report. The genomic testing results below the clinical information section are the actual results coming from the Mammoprint and Blueprint official report. In this case, the patient has a Mammoprint index of positive 0.300, placing this patient into the Mammoprint low-risk category. And by Blueprint, this patient has a luminal subtype, therefore characterized as luminal A. And you can see along the slider there where this patient's specific Mammoprint index falls in the continuum from ultra low to high risk 1 and high risk 2. The bottom of the first page are the clinical implications derived from observations from our clinical studies. They include neoadjuvant chemotherapy planning, adjuvant chemotherapy planning, and adjuvant endocrine therapy planning. In this case, for neoadjuvant chemotherapy planning, the Mammoprint low-risk result yields a probability of pathologic complete response of 2% based upon data from the NBRAS trial. For adjuvant chemotherapy planning, data from the MINDAC trial would suggest that there's no likely chemotherapy benefit for this patient, with a less than 1% expected benefit of the addition of chemotherapy. The 5-year distant metastasis-free interval is classified by node status, with a 98% distant metastasis-free interval for node-negative patients and a 96% estimate for node-positive patients, again from the MINDAC trial. For adjuvant endocrine therapy planning, the recommendation is to consider, based upon various sources of data, including the Stockholm tamoxifen trial, that 5 years of endocrine therapy would be the standard of care for this patient. Importantly, the absolute benefit of extended endocrine therapy is an important factor here for this patient, based upon data from NSABP B42 with supporting data from the IDEAL trial. This indicates that for Mammoprint low-risk patients that are not ultra-low or high-risk, that there actually is an observed and expected benefit to extended endocrine therapy for a full 10 years, as measured by breast cancer-free interval, with a risk reduction of late recurrence for lymph node negative patients of 4% and a risk reduction of 12% for lymph node positive patients treated with extended endocrine therapy. On the second page is the graphic representation of data regarding neoadjuvant response. At the top are data from NBREAST and FLEX, showing that with a low-risk Mammoprint and luminal Blueprint subtype, the expected pathologic complete response to neoadjuvant chemotherapy would be 2%. And at the bottom, you see the continuum of the increasing likelihood of pathologic complete response as the Mammoprint index goes from ultra-low to low and into the high-risk range, with significant pathologic complete response predictions in high-risk 1 and 2. On the next page is the adjuvant systemic therapy planning for chemotherapy at the top, endocrine therapy at the bottom. The data at the top are from the MINDAC trial, showing the 5-year distant metastasis-free interval for clinically high-risk Mammoprint low-risk patients that are node-negative with and without chemotherapy, showing the lack of any significant benefit to the addition of chemotherapy. On the right are the data for lymph node positive patients with a similar finding, no significant benefit for the addition of chemotherapy for a Mammoprint low-risk patient with 1 to 3 positive nodes. At the bottom are data from the NSABP B42 study, again stratified by lymph node negative on the left lymph node positive on the right, showing the benefit of extended endocrine therapy at 5 and 10 years, showing that 4% improvement in breast cancer-free interval with extended endocrine therapy for node-negative patients, and a much more significant improvement for the node-positive patients. On the final page are the references from these clinical studies supporting the clinical implications listed on the first page of the summary, as well as additional patient information. Thank you.